Our next speaker is Dr. Robert Centor. He is Emeritus Professor of General Internal Medicine at UAB, and he's going to be talking to us today about teaching cognition.
We're going to talk about mystery novels. When I was growing up, I loved mystery novels, and I think that's why I ended up being an internist, is because I love solving the mystery. I read a lot of mysteries, I watch a lot of movies, a lot of television shows that are mysteries, and I started to realize that the people who write these actually have great insights into how we think as physicians. So what I'm going to do is I'm going to share some of the thoughts that I have about this and how this might make us better at our jobs of making diagnoses. And to me, there's nothing more satisfying than solving the mystery of what's going on, whether it's a simple mystery or a complex mystery. Now, hopefully there's some people in the audience that have heard of this movie, The Thin Man. Please raise your hand if you've heard of The Thin Man. Good, a few people. Well, it's one of the great old movies, but it's based upon an even better book by Dashiell Hammett. And I love this quote. This quote is actually the deepest quote we're going to have. The problem with putting 2 and 2 together is that sometimes you get 4 and sometimes you get 22. And what does that really mean? It means to me that a lot of times someone comes to see us in our office or gets admitted to the hospital and it seems pretty clear what's wrong with them. And then 3 days later you realize they're not following what the textbook says should happen or what your experience said should happen. Maybe it's not as simple as 2 + 2 = 4. So there's no way to give this talk without thinking about Sherlock, who is many of our heroes. When I think of him, there's 2 things that really strike me that relate to medicine. The first is observation. The whole thought of Sherlock, and remember Arthur Conan Doyle is a physician and he trained under a physician who was great at observing things, which is why we have the tricks about Sherlock saying, well, this guy obviously just got divorced and he works in a coal mine and how does he figure all that stuff out? Because he's actually observing. And the other thing that he is great at is deduction or type 2 thinking. Let me just remind you what type 1 and type 2 is. Type 1 thinking is a woman comes into your office and just got back from her honeymoon and has dysuria and cloudy urine. Well, you know she has a UTI and you really don't have to go through, it's just intuitive. And a lot of things in medicine are intuitive. You see them, you know what they are. Type 2 thinking is when we go through a broad differential diagnosis, when we actually have to concentrate. Most of what we do every day is type 1 thinking, but he excelled in type 2 thinking and talks about how he goes through all the different things. The famous story of the dog that did not bark in the night, the curious incidents of the dog in the nighttime. This is a patient that I saw a little bit over a year ago in December. It was a 55-year-old man who was brought to the emergency department at our VA for confusion. The wife told us he'd become progressively confused over 2 days. In the emergency department, they measured his blood glucose. It was 800. He had no acidosis. He had a normal anion gap. He gets admitted to the ICU. Fortunately, he was a VA patient, so we could actually get his old records. He had just moved to Birmingham from California, and they documented he had type 2 diabetes for the last 6 years that they were treating. His prescription was 24 units of a long-acting insulin with 5 units of short-acting insulin with each meal. He told the ICU physicians that he really only took 12 units for his long-acting and only took the 5 units in the morning. So that's one thing you need to know about this patient. In the ICU, he had a urine drug screen that was positive for cocaine. I know y'all have never seen this before, but our patient actually had. He must have been in the room with somebody, I don't know. His blood glucose corrected very quickly. He had 2 episodes of hypoglycemia in the unit, and true to our thoughts, his hemoglobin A1C was 14. He's then transferred to the floor, and just remember, it's better to give than to receive. I received. So if you're going to teach cognition, one of the most important things to know is the concept of problem representation and illness script. How many people have heard those words before? Okay, good. For those of you who haven't, there's an article in the New England Journal of Medicine in 2006 by Judith Bowen, B-O-W-E-N. Find that article and read it. If you want to teach medicine, this really is fundamental. I'll try to explain it, but her article is so good that you need to read it over and over again. So an early step is the creation of a mental abstraction or problem representation. It's a short summary of the specific case in abstract terms. So we're going to try to boil down what we know about this patient, and we're going to go through several iterations. This was a 55-year-old man, cocaine positive, poor diabetes control, poorly adherent, and middle of the hyperosmolar state. Right? Will everybody buy that? So we've now framed this guy in our mind. It's all his fault. If he would just listen to us and get away from the cocaine, everything would be fine, right? Nothing to be excited about. So the problem representation tells us he has type 2 diabetes, he doesn't agree with what we recommend, and he uses illegal substances. The hell with him. And we think we know he had an elevated blood sugar. When he comes to the floor, though, the thing that bothered us was that he had brittle diabetes. And I'll talk a little bit more about that in a second, that he had 2 episodes of hypoglycemia. We asked the question before we see the patient, we're about to see the patient, is why is a patient with type 2 diabetes at 6 years on insulin and no oral agents? So we asked him. And why does he so easily develop hypoglycemia? And the VA records from California said that he had developed hypoglycemia several times in California. My experience with type 2 diabetics is they're insulin resistant and it's really hard to make them hypoglycemic. So it's starting to not make sense. We had a low census, we had a lot of time to think. I had a great resident, great intern, and we loved cogitating. So we go to the bedside. So they've presented the patient to me, we now go to the bedside, and the first thing that strikes you, if you're Sherlock Holmes, or if you're alive, is he has a BMI of 13. That is not a typo. This was a thin man. We started out with the movie The Thin Man, and it does relate to this guy. He knew he had diabetes for 6 years. He thinks he took metformin at one time, but it really didn't do any good. And we had no evidence of infection or coronary arteries disease. He did not have acute coronary syndrome. So now this has us a little befuddled because now we have a very thin man with brittle type 2 diabetes for 6 years. So we ask ourselves, does this fit our illness script for type 2 diabetes? So what we do is the illness script is what you expect. And I'm going to give you an example of 2 illness scripts. First, one for community-acquired pneumonia, which we'll use later on, and one for type 2 diabetes. So these are the features that you match against your problem representation to see if you have a match. And you're doing that intuitively in your mind all the time. So for example, community-acquired pneumonia, I expect a short duration of symptoms, a productive cough, fever, sweats, and or rigors, an abnormal chest exam, and a compatible chest x-ray. If something in here is missing, and I'll give you an example of that in a few minutes, it might not be community-acquired pneumonia. I don't care what the emergency department said. This is off the top of my head. I'm sure that if there are any endocrinologists, you can come up with a better definition than me. But when I think of type 2 diabetes, I think of at least overweight, if not obese. They're usually on oral agents at 6 years, and they rarely get hypoglycemic. So we actually took time to think. He had brittle diabetes. Could he have LAD, or latent autoimmune diabetes of adults? Well, we thought that was a good idea. But they developed ketoacidosis, and this guy didn't have ketoacidosis, so he has some insulin hanging around. Because of his low BMI, we considered the possibility of pancreatic diabetes. And I'd seen several patients with pancreatic diabetes, and I knew that he had the right body habitus. This was after about 10, 15 minutes of talking about the guy. I said, this happens to be type 3C diabetes, if anybody is into nomenclature. So we go back to the patient, we. That's attending speak for the resident intern. Went back and talked to him again. This was not documented in his records. He had 2 or more episodes of acute pancreatitis in the past at outside hospitals outside the VA system, so we couldn't get any records of it. And he'd had a partial pancreatectomy, according to his history, at a private hospital. And his diabetes started at the same time his steatorrhea started. So now, our problem representation is a very thin man with brittle diabetes for 6 years, starting after partial pancreatectomy, who also has steatorrhea. It's a totally different story than we started out with. And it's because the story never made sense until we got to this point. There were too many things that didn't fit. Now, the implications of this is we revised our diagnosis. We now know that he has pancreatic diabetes, which changes how we treat him, and maybe pancreatic enzymes will help him. He'd never been tried on those. Anybody but me know about Harry Bosch? So Harry Bosch is, Michael Connelly is a great mystery writer. Harry Bosch is a police detective who is over the course of 20 books has retired and does cold cases. It's also a television series on Amazon Prime. There's 3 seasons of it. It's absolutely brilliant. And Harry Bosch has a couple of characteristics that I think are really useful for physicians. He is persistent. When he feels in his gut that he doesn't have the right answer, he keeps on searching and searching and searching. And you can all think of times as a medical student, intern, resident, or faculty member where you're taking care of a patient and you're just not happy with the diagnosis and you just keep digging and digging and digging. And one of the ways he digs is he reviews the old records. In police stories, it's called the murder book. And all the data are put into the murder book. It's like the medical record. And he'll take the murder book home and search through it and read through it and stay up all night. There's a little hyperbole in these books. And the other thing he'll do is, when he's stuck, he'll discuss the case with a friend. This is one of his quotes, and this is a wonderful quote. I've learned over the years that sometimes if you ask the same question more than once, you get different responses. Now, remember when you were a medical student or a resident and you took the history from the patient and you asked all the right questions, and the attending came in the next day and he or she got a totally different answer, which totally solved the case. I'm going to tell you the opposite. It's the case of the young woman with mysterious C. diff diarrhea. So, again, this is a true story. I think she was about a 28-year-old woman, comes into our service for severe diarrhea. As we're getting ready to make rounds on her, we get a call from the lab. She's C. diff positive. So we all put on our gowns and gloves, go in and talk to her. Nobody had suspected C. diff, but they just sort of ordered it. I'm not sure why. Maybe the ER ordered it. And I asked her about antibiotics, and she hadn't been sick. She hadn't taken any antibiotics. So we went out, and I had this great discussion about community-acquired C. diff. It was on the rise, and let's look up and read about that for tomorrow. Come back to rounds the next day, and the resident pulls me aside and says, I went back and talked to her again and asked her again, and she had a UTI a week ago. It was on Cipro. The second person always gets better history. And so sometimes you can be the second person. What I tell interns and residents is go in and re-ask questions that the answers don't make sense before I get there, so that you won't be mad at me because I got the right answer. He also says this, I don't have all the answers, but experience told me they would come. So this is a case about persistence and not brilliance. We finally got to the right answer, but we didn't get there as quickly as I would like, or when you hear about the story, probably you would like. This is a 41-year-old Hispanic man. He had left Mexico 7 years ago and had not been back, and really didn't have any history of being sick when he was in Mexico. He had 4 days of progressive dyspnea and fevers. He had no previous illness. He was a field worker in North Alabama. He had clear sputum with occasional blood streaks. Other than dyspnea, he felt well, and he denied orthopnea or PND. He's obviously sick. He's febrile, tachycardic, and his O2 saturation for a 41-year-old is really lousy. He has decreased breath sounds on the right. His heart exam has tachycardia, but no murmurs or rubs or gallops. He has no peripheral edema. He's anemic, and nobody really noticed that he was anemic. We get so used to people having hemoglobins of 10 that we forget to call that anemia. We really don't call it anemia until we're ready to transfuse sometimes. So we missed one clue. Well, I didn't pick him up till the 9th day. I didn't miss that clue. But the team missed the clue. I love electrolyte panels. I couldn't find anything in the electrolyte panel to be excited about. His chest x-ray, which I hope you can all see, it's obvious that there's a lot of stuff going on the right, a little bit on the left, and you can see it on the lateral also. This is read as multilobar pneumonia. So ask yourself, what would you do for this patient? Okay? So I come in on day 9, it's a Monday morning, and he's been on antibiotics. Infectious disease has changed the antibiotics multiple times. He's had most tests known to infectious disease, and infectious disease has a long list of tests that they know how to do. Nothing has shown up. They had considered a bronchoscopy, and the pulmonologist delayed it until that day. He was going to do it. His PA films. This was his original PA film, and this is the new PA film, and you can see that it's significantly different. It's the infiltrates moving around, which is sort of strange. Now, I didn't concentrate on this guy enough. This was one of 16 patients I was picking up, including 3 new patients. And remember that in the fog of war, you sometimes don't take time to breathe. You just try to stay alive. Here are the clues that I didn't realize for about another 12 hours. His hemoglobin was slowly decreasing and is now less than 8. He actually expectorated blood right in front of me. It just coughed up blood, and he had iron deficiency anemia. It wasn't till 5 a.m. the next morning when I read the bronchoscopy report, and yes, I do get up at 5 a.m. because I usually am working out at 6:15, and it was fresh red blood cells. So he had pulmonary hemorrhage. I then went back to look to see pulmonary hemorrhage, what else is going on. And nobody had noticed, because it's technically within normal limits, his creatinine had gone from 0.8 to 1.2. Now, if he'd come in at 1.2, we might not have gotten excited, but if it goes from 0.8 in 9 days to 1.2, I said, it's probably a clue in the urinalysis. There's no urinalysis, so I did something that I've never done. I paged the intern and said these words, which I think is the only time in my life I ever said: we need a stat urinalysis. And the only reason is because I wanted to know what it was when I got there at 8 a.m. And he had 180 red cells and no casts. So what do you think he had?
40 catheter. 40 catheter.
He did not have a Foley catheter. So it's polite to say granulomatosis with polyangiitis, because Wegener was a Nazi, and we don't like Nazis. I thought it was good pastures. I was 100% wrong. It was granulomatosis with polyangiitis, because good pastures is 1 in 10 million, and granulomatosis with polyangiitis about 1 in a million, and it's the most common cause of pulmonary hemorrhage. So, and he had a very stormy course. Ended up in the unit and intubated, but eventually did get better and was started on rituximab. This is the latest book by Michael Connolly. I think it's the 20th or something in the series. And there's a clue here. They're trying to frame Bosch with falsely putting a killer into prison. And there's a video where they unpack the old evidence, and it looks like Bosch has tampered with the evidence. He looks at the video over and over again. He can't find anything, so he asks a colleague to look at it. And the colleague looks at it and notices something that Bosch didn't notice, something that, just because this guy had an expertise, which ends up being the key evidence in the case. Hopefully you all do this. I do this all the time. When I'm getting a little confused about a patient, I find a colleague. Sometimes it'll be my resident, sometimes it'll be a junior colleague, sometimes it'll be a senior colleague, and tell them the story. Sometimes when I'm telling the story, it starts to make sense, and by saying it out loud, I say, oh yeah, that's what it must be. And sometimes they're just smarter than me. Benedict Cumberbatch, how many people have seen the BBC series? If you like Sherlock at home, you have to watch it. In the second episode, he says this: you have a solution that you like, but you're choosing to ignore anything you see that doesn't comply with it. Agatha Christie said it slightly differently. It often seems to me that all detective work is wiping out your false starts and beginning again. That sort of sounds like medicine when you have a complex patient. It's very true that, and it's just what some people will not do. They conceive a certain theory and everything has to fit into that theory. This is called premature closure. So once the patient has a label, it's hard to get away from that label. This is why I'm so upset with our healthcare system that requires the ER to put a label of diagnosis before the patient can be admitted, otherwise the insurance company won't pay for it. And that label leads to diagnostic errors. And the two biggest are community-acquired pneumonia and cellulitis. If one little fact will not fit it, they throw it aside, but it's always the facts that will not fit it that are significant. In that previous case, the fact was that his sputum wasn't purulent, and yet they kept on treating him for infection. This is a case in which my house staff did a brilliant job. It was a 56-year-old man who was admitted with 4 days of progressive dyspnea. He had a minimal cough, 2 episodes of clear pink-tinged sputum, denied fevers, rigors, felt chilly, no respiratory tract symptoms, routine labs are unremarkable, and he has this chest x-ray. Radiology at the hospital that will not be named read this as left upper lobe infiltrate. Two problem representations. The emergency departments diagnosed community-acquired pneumonia, and they said it's progressive dyspnea of the left upper lobe infiltrate. The internal medicine team, and one of the reasons the internal medicine team got this right is because it is very clear to all the house staff that community-acquired pneumonia to me is a chance to be a diagnostic wizard, and that you never believe the ER. And I'm not blaming the ER. They have to put a label on the patient, but it's our job to second guess the ER. And if we don't second guess the ER, we're not doing our job. Progressive dyspnea, no purulent sputum, no fever, no rigors. They said, it's probably something else. So he was admitted with a diagnosis of community-acquired pneumonia. The house staff was skeptical. He got a pro-BNP, which was 900. Just exactly the number that doesn't tell you anything. So they got an echocardiogram, and he had a left ventricular ejection fraction of 30% with increased pulmonary artery pressure. And they cathed him, and he had dilated cardiomyopathy. If you really like all those numbers, you can read them. I saw him 36 hours later, taking a careful history. He'd had progressive dyspnea for 2 months. He had a history of untreated hypertension that he knew about, and he had the loudest summation gallop I've ever heard in my life. The third-year students had no difficulty hearing this. Why was this guy missed in the ER? Well, they didn't take a proper history. Now, in their defense, they don't have time to take a proper history. They were right, he needed to be admitted. He just didn't need to be labeled. The radiologist read the x-rays and infiltrate, didn't notice the cardiomegaly, didn't notice the fluffiness in all the lobes, because at this hospital, the radiologists try to read too many x-rays. It takes time to read an x-ray just like it takes time to do a good history and physical. A lot of people have inadequate physical exam skills. That's our fault. We don't teach it well. We don't emphasize it. We don't reward it. And you can make the mistake because of diagnostic inertia. We have to go back to our hero, Sherlock. The world is full of obvious things that nobody by any chance ever observes. So what we need to do is teach people how to observe and explain why it's important to observe. So here's my advice for those of you who teach either whatever you teach. Focus on problem representation. Get the residents and the students and the interns to summarize the case after you've heard it, and then see whether or not you agree with that summary. Did they leave something out? Think out loud. Talk to hundreds of students and residents. They don't care what you know, they care how you think. So be very explicit. I had a chief resident tell me the other day, he just started doing ward attending, and he said, I learned how to do the physical exam, but nobody ever told me why I was doing the physical exam. And now he's trying to learn himself how to teach the students and residents why we're listening to the lungs in this way, what we're looking for. It's not just that we're listening, but what are we looking for and what's the implication of that? And that's true with lab tests and everything else. And we have to be a role model searching for more clarity. We don't have all the answers. And I had a very interesting chest x-ray recently that was a little confusing to me when I looked at it. I always look at the x-rays even though the radiologist has read them. So we walked down to radiology, found the radiologist, and he taught us a lot about the chest x-ray. We had a much better idea and didn't have to order some other tests that we might have ordered because we actually communicated with the radiologist. The house staff and students were really excited about that, and it's the right thing to do. I hope I've given you some ideas about how to teach the thought process and how to think about the thought process, and if not, I apologize. Thank you all very much.